This is the first navigating healthcare that we've done. We've done repeated annual updates. We've done repeated Ask the Expert. We've done 2 housing ones now. They're well attended. What else have we done? Guardianship, tax, disability credits. We've done one on getting ODSP benefits increased. And I have to make a note about that. Just 896 and 69 SERB. There we go. So anyway, so we've been doing this for a while. Basically, mostly since 2015. More actively in the last 3 years. And of course, now with the virus and all that, more people have webcams, more people do things this way. You see your doctor this way now, right?
Yep.
Which is great. It's absolutely great, I think. Why the hell should you drive there, park, wait for half an hour, see the doctor for 10 minutes to say that the results were fine, and drive back? Right? Makes no sense, does it? But obviously the stupidity of it is that there was no billing system to do this, so they had to have you come in for an appointment to get paid. Duh. Right, so that's how antiquated the whole damn system is. One of the, so it's 76 attendees, that's good, that's a start. What Diane's gonna do when she touches on legal guardianship is she's gonna give some horror stories about why people are literally driven to us by the neglect and abuse and misdirection that they receive from doctors and hospitals and supporting professionals and all that. And I'll talk a little bit about the fact that, in the context of what we're doing here, it's the parents who are the experts, right? They've known this child since day one. They're the ones that have carried this message and kept track of all the medications and all the adverse effects and all the things that have been tried and what didn't work. They are the experts. It's not the doctors and the hospitals, frankly. They just sort of, do their honest best, I suppose, to make their contributions, but even then, you see enough doctors and others that, just don't get it. And I'll try not to spend too much time, but I'll tell a few anecdotes, about the father who had a daughter with scoliosis who was 13 and she was in a growth spurt. And so she was getting more and more bent over and it was affecting her breathing. And so the doctor that, I guess a pediatrician, I suppose, but maybe a scoliosis doctor, I don't know. So anyway, the dad called me because he had wanted the girl to have the standard scoliosis straightening surgery. And a buddy of mine, who's a year or two younger than me, buddy of mine was scoliosis patient number 2 in Ontario. And he was in a body cast for like 6 months, right? Well, now it's an in and out thing. But the doctor that the dad was talking to said, oh, she'll just have to get used to it. So of course, dad took her down to the Shriners Hospital in Montreal and had the operation performed. My clients are not going to put up with this garbage, right? Who would? It's just that you have to fight a little harder. Anyway, that's my rant for the day. So we have 94 people so far attending. It's 4 minutes after. We'll give it another few minutes. People, we're all just human beings, right? So they'll log on, a little bit longer. I would think we'll probably wind up with about maybe 150, something like that. Does any of the panelists have any questions about how this is going to proceed or what they'd like to do?
I sure don't. I did want to say, Ken, thank you. I've had a couple of referrals from you in the last few weeks. I appreciate that.
Your people have done a great job, by the way. I'm going to use one of those stories, if you don't mind. I won't name names, but.
Great, my pleasure. But thank you very much, because I know that a lot of people would come to us if they knew about us, and it just hasn't happened that everyone knows about us yet.
Mm-hmm.
So
I'm looking forward to knowing more.
Oh, Susan's got a great thing going. It's an absolutely great thing. So I'll do a brief introduction of the 4 of us. Then I'll touch on slides 2 and 3, I think it is. Dianne will do slides 3 and 4. And then I think after that, we morph into the slides for Lisa and then the slides for Susan. And after we've talked for an hour, there'll be 15 minutes to answer more questions. And it's just an ongoing thing. Just if you have thoughts and comments, you know, oh, and what you're saying is absolutely correct. I remember a time when it's the stories, the human interest stories, the fact that, you know, families are just families working from day one to try to take good care of their kids. You know, that's what this is all really about. And it's not a matter of, you know, commiserating or complaining. That's not it. My clients, they're not complainers. They just want what's right done for the child. So Dianne will give some stories about that, about what the people that have been, you know, they need more clout, basically. I've got 102. It's 7:06. I think we should get started. You all set?
We're good.
Okay. So I'd like to introduce myself and the panelists. I think that probably everyone that's taken part knows my firm. We specialize in working with families with kids with disabilities, special needs. We do wills and hence and trusts and ODSP applications and appeals and disability and caregiver tax credit recaptures and benefit increases, illegal guardianship. We do about, you know, roughly 13 things that fit the profile of our client families within this special niche. And all across the province, more than that too, you know, other provinces, other countries, but primarily Ontario. And we've just developed this since 1996 and just kept adding on the things that our clients need. So, you know, for example, we added on legal guardianship back in 09 because in December of 08, RDSPs came into place. And at that time, the parents could not be account holders. So if you had a child who was not competent, they couldn't, if you had, you know, an adult child who was not competent, they couldn't have an RDSP because nobody was their legal representative. So my clients needed legal guardianship. So we figured out how to do that. You know, all of our files, Dianne and Rafiga do these, but they're all uncontested. They're all filed in Ottawa for across the province. I don't think anybody else does that because most of the firms that I know that do legal guardianship, they're contested legal guardianship. So anyway, I'll carry on from here. So this is Dianne Verano. Dianne, you have what, 4 degrees, I think? Or I know you've been working your way through. You're working on your TEP accreditation now. So it's nice to have people. Nice to have staff that are smarter than you. You know, it's a whole lot better. Susan Hagar, who's a nurse, registered nurse, and she's as you can see, the founder and chief executive officer of Nurse on Board. And what Susan does, her firm does, is they provide nurses to go with people, such as your mother, and they go, among other things, they go to appointments, they make sure medications are correct, they see that there's no unnecessary adverse effects, they handhold, they report to the parent, to the children, or whomever they're reporting to. Susan, you can, you know, embroider this, but basically they're skilled, accredited, trained nurses who can talk the language of the doctors and nurses and other supporting professionals. And frankly, it keeps them on their toes. You know, they know that they're being talked to and watched by peers who know how things are actually supposed to be done, which I find invaluable. Lisa Pelletier is the owner of Welcome Home Residence. And we've been working with her for a couple of years now because inevitably there's a transition from home life to other supported living arrangements. And one of them could be a supported home residence as Lisa manages and runs. And Lisa, you know, when you come to your part, feel free to embroider on that as well, okay? So I see we have 110 registered. That's a pretty good number. That's probably what we'll wind up with here. So in order to navigate healthcare, if a person is competent, the best thing to do is to have them, if they're over 18, to, well, they were 16 actually, to sign a power of attorney for personal care. What this does is it appoints a person to be the legal representative of the person who's competent to help them with medical decisions, understanding and appreciating the implications of treatment. Because in order to be properly treated, people have to have what is called informed consent. So a personal care power of attorney allows you to have someone legally help you with those things. It's always normally bundled with a will, with lawyers. But we do a lot of them for the parents of children once they're turned 18. Technically, it's age 18, but I won't go into that. And what this does is it allows the parents to speak with and receive information from doctors, hospitals, medical professionals, supporting professionals, psychiatrists, psychologists, therapists, all of these, where normal privacy legislation would not let them be told this information to help their child have informed consent. And frankly, you have to keep in mind that, for example, for a nurse, especially, to disclose information that breaches privacy, client privacy, it's a firing offense. So you can't really argue with them. You just have to set up a situation where they can give you information. Now, the problem, of course, is that even with powers of attorney, or when medical professionals are speaking directly to clients, patients, they think they know best. And as far as I know, they may know a great deal about their thing, but in the balance of things, in the span of life, and in the balance of judgment and decision making, they don't know. It is often the person, the child, of course, but by definition, we're dealing with kids with disabilities and special needs. And what my client families want to do is to help supplement this, buttress this, to see that their child is not neglected. And that's their lifelong task. So a lot of times you're ignored, even if you have a power of attorney. So I'll go to the next slide. This is just about power of attorney for property. And it's the same thing. It's given and it can be canceled. It's effective before a person is incompetent. It remains in place if they become incompetent. That's called a continuing power of attorney. Very rarely you'll see what's called a springing power of attorney, where it only becomes effective if somebody has been deemed incompetent, or their doctors, often sometimes a named doctor, determines that the person is not capable. But it's for property rather than personal care. That brings us to substitute decision makers. Dianne, I think I'll just touch on this, and then I'll stop with the guardianship. A substitute decision maker, there is a hierarchy, a statutory hierarchy of, if a person is not competent, who is their substitute decision maker. So it would, for example, be a parent is a tree, a spouse, a child, or at the top of the ladder is a legal guardian, or a person who's been granted power of attorney. And so, for example, we sent out a bundle of power of attorney papers the other day to a parent mother who wanted to have power of attorney for her child. And someone, I think it was a nurse in a health facility, I think, who had asked why she would pay to have a power of attorney for personal care when she was already a substitute decision maker, which is technically correct if her son is not competent. But of course, if he's not competent, he can't sign a power of attorney, for one. And then second, it's only as to personal care, not property. And then thirdly, there's no piece of paper, there's no notarial copy that you can provide to a doctor wherever you happen to go, whether it's Florida or wherever. It says, I have the power of attorney for my child. And I can tell you frankly that the reason that people are dissuaded from doing the more definitive work, whether it's powers of attorney or legal guardianship, is just because, as I said, they think they know best. And if there's nothing in writing and there's no lawyer on the file and they think they can get away with it, then what they'll do is what they think is best, and they'll inform you about what they want to tell you, which doesn't mean they're going to tell you all the options or the best implications of these choices, because they think they know best. And it makes their life simpler. I had a client, an old friend and client, and to make a long story short, her mother was at home. They were caring for the mother. 88, she just died last week. And she had some sort of problem, and she needed something lanced. And so the doctor that my client had been dealing with had arranged for this doctor. He had agreed to come to the home and lance it. It's not a big deal here, right? But then somehow another doctor got involved, and he didn't feel like it. He told my client that she should take her 88-year-old mother, who died on last Thursday morning. They should take her to the emergency ward at the Civic and wait for 12 hours so someone could do it there. And this is the wonder of our one-pay system. So I referred them to Susan, and Susan, as far as I know, someone was arranged to go and actually do this at the home. So this is just the subjective nature, because the medical system is clearly biased against people with special needs or disabilities and old people. If you're a broken bicycle, why fix the tires? That's just a fact. Now, I'm not being cynical here. This is just a fact. Now, it's true that a lot of people get better treatment than that, and I applaud that. But the problem is, what about those of my clients who don't? That's the issue. So with that little comment, I'll stop my rant, and I'll turn it over to Dianne to talk about the horror stories that drive people to us to seek legal guardianship. Dianne?
Hello, everybody. Good evening. Thanks, Ken. So like you said, Ken, because of the nature of our business, we do get phone calls or emails from people who are experiencing problems that affect their ability to make decisions on behalf of a loved one with disabilities. So I've just prepared a list of the things that people contact us for, and it was pretty easy to come up with this list because these are common problems. It can be as simple, if we're talking about property, not being able to access a bank account. So if you're dealing with an individual who can contemplate money, but maybe they're very trusting and they're susceptible to financial abuse, maybe it'd be good to have someone there, like a guardian, who can manage those funds for them. Just make sure that they're not being taken advantage of. We did have a client who she had established a relationship with someone from outside of the city who she's never met, and this person was asking for money, and she just gave the money easily, and it was not until her brother came to us seeking guardianship that we could prevent this person who she's never met from taking advantage of her. We also get phone calls because our clients aren't able to access more funds for their child. Sometimes organizations do ask for documentation, that the parent or the family member or the friend can make decisions and can apply for more government funds, or even applying for pension or death benefits if they are the appropriate age, signing forms for college or for school to make sure that they can access their report card, or can consent to things that are going on in their classes. And if we're talking about personal care, I did have a client who decided to proceed with guardianship. Amongst other things, it was difficult for her to book a dentist appointment for her daughter who was nonverbal. And when she called the secretary, the assistant said, I'm sorry, I can't book this appointment. Your daughter needs to. And so, what do you do with that? My client came back and said, well, she can't book her own dentist appointment because she's nonverbal. Again, not being able to access maybe medical records. And then because of the nature of our business, we do hear stories of abuse, maybe from visitors to, let's say, a group home, or just the people that are around this person with disabilities who can't communicate for themselves. They might need someone who can make workers realize that maybe something's going on here that isn't right. We also have clients who, as they age, their parents pass away and they're coming into an inheritance, and it's a large sum of money. Who is going to make decisions about this large sum of money because the person with disabilities can't? There's also just asking other things that maybe are not standard. So maybe the home that the person is staying in, there's a standard way of doing things, but that standard doesn't work for your family member. So one example is that I had a client who brought in a big screen TV, a bigger TV for her husband because she thought it would make him more comfortable. He likes to watch TV. It just happened to be bigger than all of the other TVs that his roommates had. And they told her, sorry, this is not a standard size. He can't have this TV. And it's not because it's an incorrect request, it's a request that hasn't been made before. And everyone's story is different. Everyone's level of being comfortable is different. And it's also, we want to give these people who don't have the ability to speak just a voice. So to what extent are the people around this person going to listen to someone without a voice? Again, I had a client whose husband was very ill, and so she wanted to stay with him because she wasn't sure whether, she was going to say goodbye or maybe she'd say goodbye in a week, and she just wanted to stay with him because to her it didn't feel like he looked well. And the people around him, the healthcare people, workers around him, wanted her to leave, and they even accused her of trespassing. And they told her that she was bothering him, that her presence, was not helping him at all. So I could go into more examples, but these type of examples are the ones we hear typically.
This next slide, and I think this is our last piece, is the clause that is in a lot of wills when you're dealing with minors, and it might get carried over for adults. But of course, one of the hardest decisions when you're a parent is who would be the guardian of your child if you pass on, right? So that's always the toughest question. The division of your estate, that's just money. But what about to care for your child? Where will they go? And it's often misunderstood that the guardianship clause in a will, which deals with a minor especially, might be valid 60 to 90 days after your death, but you can't appoint a legal guardian. It's like a mother who comes to me and says, I have custody of my daughter. I don't want my husband to get involved when I die, so I want to give my sister, the aunt, custody when I'm dead. Well, of course, you can't do that because it's the court that grants custody and the court that grants guardianship. So you'll see these things, and it's a nice recommendation, but it has no legal effect. And I think that's just about the end of it for us. Let me just take a look, Lisa. Yes, so Lisa, over to you. Would you like to say a few words and then carry on with your slides?
Lisa, you got to unmute yourself.
There we go. Sorry about that. Hi, so my name is Lisa Pelletier, and so thank you, Ken, for inviting me to be on this panel this evening. So I just wanted to share my experience in navigating a complex system when it comes to, as a parent, if you do decide that things just are a little too difficult and for whatever reasons, the needs of your child surpass what you can offer as a parent. And so just navigating that system, I would like to share with you. So I'm the owner and operator of a single family group home. So it's a very small private group home. We're a little bit unique. We're kind of a boutique home, if you will. My parents actually started the home 25 years ago. And just recently, my brother and I took over the family business, if you will. And so some of our residents have actually been with us. We actually started off as a children's home, but obviously 25 years later, so now we're adults. And so I've really seen the whole gamut from infancy to adulthood. If you want to go on to the next slide there.
Okay.
Mm-hmm. Perfect.
Karen, do you have any idea why we're not getting more questions?
Oh, there we go.
But sorry if I take myself off mute. I have not really any idea. I just checked the participant to make sure that everything was good and everybody's there still. I think people may be just listening.
Okay.
We're just so thorough. So just a little bit. So welcome to the world of parenthood. As a parent, you're excited and then you have this baby who might present with special needs. And so then there's all kinds of that emotion, the shock, the grief, the fear, the joy. And so those first 5 years, you're pretty much in survival mode. You're gathering information. I'm in the Ottawa region, so CHEO, you tap into the services and resources, and you still have to advocate hard, but it's kind of preparing you, because I'm not going to lie to you, it gets a lot harder in adult world. So this is, if you have a child under 5, this is your training. It's a lifelong journey, if you will. So if we could just go to the next slide. Perfect. So then finally you reach that school age, so that primary JK to 6. So this is a major milestone for both parents and child, right? So it's the first time that your child is going to officially leave your home into the school system. And so although it's not a perfect system and you still have to advocate, it's overall a good education system, and there's a lot of supports in place. And then once you're in school, then you actually have access to all kinds of wonderful specialists, such as occupational therapists, physio, speech, dietitian. They all go to the school. So everything just flows quite nicely. And so generally, you're getting some good service there for your child. So the next one. And then this is where I start hearing from parents a little bit more. So now your child's getting a little bit older, 12 to 15. Their needs are just as demanding, if not more, except now they're bigger, heavier, louder. If your family and friends are a little less keen to help out, it's like, oh, you get that, oh, I don't know how you do it, you must be a saint, and all of that. Uh, but here's my biggest advice to you is, start tapping into services and make yourself known. Don't try and be the superhero, oh, I got this and nobody else. It is time. I implore you, parents, start tapping into services. If there's respite services you can tap into, start expanding your network and be honest with what supports you need. So between 12 and 15, that's when you should really, if you haven't, some parents get started right away because the needs are so complex. But, this is a really critical time to really start to get that ball rolling. We'll get to the next slide. And then now between 15 and 18, start making some noise. You have to start seriously planning, okay? Because life after 18 in the special needs world is a whole different world as far as tapping into services, accessing funding. You see, when they're under 18, the ministry is mandated to serve. Once they're over 18, they're not mandated. Nobody has to do anything. So it's really, really critical. If right, that you're burning out at a fast rate, then it's time to really tap into those services and seek help and get those social workers, or certainly like here in Ottawa, service coordination, start tapping in and accessing that and making yourself known. Demand respite and start sort of going that route. Because then we'll go to the next slide.
Okay, just a sec.
No.
Let me do this again.
Oh, there we go. So now, you magically turn 18 and correct me if I'm wrong, but the law is really funny. Like, it's like all of a sudden, oh, you're an adult, you have your own decision maker, you're everything. And then the parents all of a sudden who have been advocating for 18 years are kind of not really heard, they're ignored. And so, you should have, then you get into DSO, so you'll register, and so you're a little bit encouraged, right? Because you think, oh, good, so you contact DSO and you're going to register your now adult child. And it seems like a good process. They'll come in, they'll do a SIS, a support intensity, so you get all this stuff and paperwork done, and you're kind of excited. And then when they do that, they'll say, so are you looking for residential supports, and so you say, oh yes, for sure, and day supports because school's going to run out soon. So you check off all those boxes and then you apply for ODSP. And so that's a little bit encouraging, right? Especially if they're at home and you're thinking, okay, he's funded. So, but unfortunately, that's kind of where it ends. I'm, giving you the real sort of picture here in terms of what the future years are going to be. And Susan can attest to that after too, but now you're leaving the safety net of CHIO, the Children's Hospital, where you're followed every year and you have all your specialists, and then you're just kind of, well, good luck to you, you're kind of discharged, and then all of a sudden there's nobody to support you in your child's medical needs. So that's another piece. So it's really an eye awakening, and at this point as a parent, you're 18 years in, you are getting tired, and your child is growing bigger and stronger, and and there's no supports. So the next slide.
And Lisa, someone is saying that they are having trouble hearing you.
Uh,
That person should try to make sure they turn up their volume as much as they can.
okay, I can try and talk louder. So now it's our new reality now that your child turns 21. This is critical because the schools at least will keep the individuals with special needs until the age of 21. But after that, then, you know, that service ends. And so this is where parents really find themselves in a huge bind because now they have no more day supports, right? And so our system, you know, like I said, it's well-meaning, but it's very, very broken. And so it's going to be rough, and you can sort of fight through that system, but you have to really yell loud and push hard, unfortunately. So the next slide.
Okay.
So this is just you know, your chart that from the ministry level and sort of how it operates, just to give you sort of a layout of how it works. So you have DSO and you do your, you know, and so they'll direct you to ODSP. And then this is where you start to see crises happen. And so they do have an urgent response because the reality is if your child, or if you're not pushing, you're not going to hear from them. The wait list for a funded residential placement is over 10 years. There's just no funded vacancies, funded beds. And so it's a long, long wait. And so the only way at this point in time, like, is through urgent response. But even urgent response, Ken can attest, I mean, we were a year and a half in urgent response, and it's a very scary, unnerving game to play. It can be done, and you know, thank goodness for the young man that I was serving. You know, we got the result we wanted, but it did not come easy. So if we can just go to the next slide.
You're right, Kelly. So it was real knuckle biter for a while.
Yeah. So here I just give a little summary sort of how things work. So, you know, what your DSO workers won't tell you type deal. So, you know, this is just the ministry of MCSS, and then you've got your minister, deputy minister, and then you come down to East Region. That's where we are here in Ottawa. And so then you have your ministry funded program. So as far as residential placement, so there is a difference. So in people like Christian Horizons, OCAP, ICSS here in Ottawa, those are funded programs. And so their money flows directly from the ministry. And so those are the beds you're waiting for, or these individuals, they also have day programs. So those are the placements you're waiting for. Now, under this, also, there's some serving agencies. So there's service coordination. And that's the agency that I deal with directly. And so then you see that as far as residential placement, service coordination deals with us, who are called OPRs. So we're outside placement resources. So we are not funded vacancies, we are private. And so typical homes like that in Ottawa, I mean, there's a few of us, so Welcome Home Residents, Sunshine Families, so those are private operators like myself. And so the number one question, especially now through COVID, that I'm getting all the time is, how do I get my child in your home? You know, and I wish I had a straight, easy answer. So it's a tough system to navigate. So what happens though, the way this works, so let's say you're a parent your child, your adult child is 20, you are burnt out, you are done. So you go to service coordination, okay, and say, I can't do this anymore. And so they'll, they'll try and find a place. And so then it goes to what's called a round table. And so then at this round table, your child will be presented and say, okay, so we have an urgent response here. So, this individual, he's got this and this and this. Is there anybody that has capacity to serve him? So they're always going to look in-house first. And so that's where they're going to go look first to try and help your child, individual. If there's nobody that has vacancy, nobody can help, then service coordination will sort of say, okay, well, let me see if some of my people have capacity to serve. So then they'll reach out the profiles to the private sector and say, is there anybody that can help? But the problem there is that it's the money. It's always about money, unfortunately. So if you're in an OPR, they're not funded vacancies. So the ministry funded programs, the money flows directly to the home. So the budget is for the house, not for the individual. And that's what the government is slowly trying to get to, is more client-centered programs where the money is attached to the individual as opposed to the agency. And so that's kind of the beauty. So once they come, if nobody can take them sort of in-house, then they'll reach out to OPRs, and then service coordination and the OPR, everybody will fight. And that's the battle that we recently went through to try and get some funds attached to this individual for residential. Because, and then often parents are like, oh yeah, no, they're in the system because they have ODSP. Well, to a residential placement is anywhere between $200 and $600 a night per day, right? Because that's just the cost, because of the staffing supports that are required, and that's the reality of the cost. And so it's significant. And so there's no way that a private individual can just come and tap into that unless they're super wealthy. And so, so the individual I came in with, so at least now, like, there's some passport funding that's been helping people at least start with some respite, that can tap into respite services and go privately. And then eventually, after lots of fighting and pushing and pleading, just to give you an example, it's a terrible game. And the situation we've just had with Ken's client, they came in with respite, and so they had a spot, and then it was a real kind of very scary game of chess where the parent said, we can't take him back. And so I went to the ministry and said, well, I have an individual here and the parents aren't coming back. And so they're like, okay, well, they'll find money for a month. And then after that, we had to go. He was presented at that table. They found a place in-house that had expressed an interest, but then we prepared this young man to go to this new group home that was ministry funded. But then at the end, ultimately, the group home said, no, we can't handle his type of needs. He's too complex for us. And so then he came back to our house, and then we had to petition again. And so, like, literally the funds were trickling in week by week, and I'd have to write letters and threaten, saying, what do I do? Like, I can't, I do need to pay bills and pay staff. And so if you're not going to support, then what do you suggest I do? And sadly, the system is so broken, it's like, call the police. Like, I'm not sure what they thought there. And so I just said, well, that's fine, but I'm not going to do that to my residents and have them exposed to that and thinking, am I next? And so I quite frankly told them, well, that's fine. Then I will bring him to your office and you can call the police and activate your plan. So again, then they magically found a little bit more money. And so it's a game, you know, and it's awful and it's heart-wrenching, but you know, as a parent, you need to stay strong, you need to advocate, call, like, you know, like go up the ministry and email them weekly, daily, call your ombudsman, call your MPP, like you have to make noise. And so if you're that quiet parent saying, oh, I'm really getting tired, you have, like, if you're, you have to fight hard. Unfortunately, that's just the reality. But you can be successful because ultimately, you know, you gotta give it your all. So that's been my experience. And so, like I say, it's to go back, you know, if that's why it's so critical, parents get that ball rolling when they're like 10, 11, 12. It's so much easier when they're children, underage, because the ministry is mandated. They can't ignore you. They have to do something with children. So that's my P.
That's great, Lisa. Thanks.
Thank you.
Susan, would you care to say a few words and then talk to your slides?
Thank you very much. And thanks for the invitation to speak tonight, Ken. And Lisa, thank you for the messaging. You're absolutely right. It doesn't get any easier. It just progressively gets worse. Ask the families who have senior parents and they're living the nightmare. So yeah, I'll carry on. And Ken, I have a lot of slides. We've got a lot of info I'd like to cover to share tonight. So I'll just say next when I'm ready. But I just want to say that a lot of what I'm covering here tonight doesn't really factor in the pandemic, but we can certainly deal with that in any of your questions after. And anything I say here tonight, where I say I'm advising you, I'm really advising you as a guardian or as a parent or as somebody who loves somebody else and you care about what their outcome is going to be in healthcare. Because many of you are parents, and as Ken said at the beginning, you are experts about your children. And certainly, we know there's a lot of trouble in our healthcare system, and although we're lucky to live in a rich country, there's huge gaps in healthcare here. And where we have excellent stories, there's just as many stories of how we've been let down. So what I want to speak about a little bit tonight is a personal reform in relation to healthcare. And although we do need healthcare reform too, and I'd like to help you to get the system to work for you. And so this is why we like to educate people about how they can get that. And that really has to do with your mindset, which is why you see this slide, which says, when you change the way you look at things, the things you look at change. Healthcare is a foreign land. It's unfamiliar. The language isn't easily understood. You don't recognize the customs. The expectations are unclear. And so this puts you at a disadvantage. And I'm going to invite you to look at your healthcare differently to get a different result. We are from a generation where people think that respecting doctors means not asking any questions, but in fact, we need to change this perspective. I would like you to think that it's your mind, your body, your business, and where you consider advocating for yourself, it gives you a sense of control when you have this attitude, because nothing could be more important if your health is at stake. So, you know, patients, their loved ones in some cases, really are the experts in their own health, and they have to learn how to communicate their symptoms, their challenges, their difficulties, their preferences. Next, please. I founded Nurse on Board in 2015 for all the reasons you can imagine, all the trouble in healthcare. That's me as a nurse back in 1984.
Pretty cute, pretty cute.
Thank you. Don't you love that hat? Well,
Yeah.
They found out after they started swabbing all those nursing hats, they found out we were carrying around so many germs that they banned hats in the mid 80s. In any case, I started the business because I had my own personal experiences and professional. I have been a nurse for 36 years. And in 2013, my mom had an ICU admission that honestly, she probably wouldn't be alive had I not been there with her. And so that really got me thinking, why can't you have a nurse to see you through the complexity of this? So the business is based on highly experienced nurses. Most have 30, 40, close to 50 years of experience, and that is why we can help with these outcomes for people. But backing up, I will tell you that my father died a young man at age 57 from a medical error. So that really set me up for being alerted to how badly things can go and how misinformed families can be. And before that, my sister, who would have what's called, was probably severe autism. She was in Rideau Regional, so we lived through that nightmare, and she was eventually placed in ICSS home in Ottawa. But we've lived through the trauma that it can be on many levels with healthcare and community care. Next slide, please. So what do we do as nurse advocates? Well, there's a list there, and there's many things we do that aren't on that list, but we are seeing our patients through the complexity of medical and community care, supporting their families, and we're really the bridge, I believe, between patients and other healthcare professionals. Next slide.
And I'd just like to comment, Susan is assisting a client family, and the 72-year-old a man who has developed some dementia was taken into hospital on the 4th floor of the General, and basically being neglected and medically restrained and abused. And so when her people got involved, all of a sudden, the doctors and the nurses there realized that someone at a peer level could see that the level of care that was being provided was inadequate and negligent. Whereas, with the family, you're always trying to, put your nose in, and they won't reply to your phone calls, and you get the receptionist and you leave a message for weeks, and like there's nothing happening. But as soon as a peer who knows how things are supposed to work, people sort of pick up their game and realize they're being watched. That's my comment.
Yes, thank you, Ken. You're absolutely right. What an unfortunate situation for a man who really should be in Jerry Psych, and they had not done a proper history. He should have been on other medications, and so we've certainly been able to help over there. Thank you. I have on the screen a definition of self-advocacy, and perhaps you've read it, but ultimately it means taking responsibility and assuming some control over your life circumstances. So in teaching someone to be an advocate for themselves, it's really about helping the doctor to help you also, because you have to start speaking up for yourself so they actually know what the problems are. And I'll ask you, what is it you have to lose for speaking up for yourself or for a family member? And, if you truly dig into what that is, I bet it is a fear around your relationship with your doctor. We've really been well trained in Canada to not want to go up against anything a physician says. Next slide, please. So I ask you to consider whether you are taking better care of your car. And I say that because think of your car. You get regular maintenance, you keep a file on it, you look for another opinion when you don't like what the mechanic has told you. If you're not happy about the cost, you also look elsewhere. So, appreciating your body as much as you do your car, then you may want to do things differently. Next slide. There are some simple strategies. That's the good news. And that's some of what I'm going to share with you now. And if nothing else, strategies make you feel happier. And that's really what matters, that you've done everything you can. And frankly, you need a strategy because it seems that in healthcare, the right hand doesn't know what the left hand is doing. Next slide. Healthcare is very complex. It is many moving parts. And so realistically, there's gaps in care. And these are healthcare providers that good people, I would hope, for the most part, working in a complex system. We've had an explosion of drugs, technology, tests, procedures, and it does feel like the humanity has fallen away from healthcare. The doctor tells me everything I need to know. That simply isn't true. They don't have time. And they also have their preferred things, and that's what they're going to tell you. But it really is misplaced trust. And so people need to adjust themselves accordingly. And as I have on this screen, who's the most important member of your health team? Well, the answer is clear. It's you, or it's the patient, whoever it is that the care is for. But we're not trained to think like this. We allow decisions to be made for us. And the truth is we have to be prepared to connect with all the members of health team. Your health card really is like a credit card. You have to swipe it at every visit. You can't go anywhere without it. The only thing is, thank goodness, I suppose, you don't get the bill. The downside is, though, that people have no understanding at all about the cost of healthcare, and they may think differently about some of the way they use healthcare if they had a better understanding. But the truth is also, how much of your tax dollars goes to healthcare? Well, it's upwards around 50%. So that means you're a healthcare consumer. That means that you deserve to understand and be understood. And additionally, 75% of healthcare costs are paid outside of the system. So where people are objecting to a two-tiered system, they have to recognize that people have been paying for healthcare probably for as long as they can remember. Next slide, please. I invite you to do homework. Look right at the word diagnosis. Well, the word know is right in the middle of it there. And you need to do some homework because knowledge is power. And so, I do invite people to use the internet. And if they don't feel capable, then to get some help. Next slide, please. It's very important, though, when we think about the internet, we're saying don't go to Dr. Google, that's a bad idea. Well, the reality is people are doing it. So to say not to isn't realistic, might as well help them to do it right. People can be responsible, and the credible sites, reliable sites are the ones that are university, hospital, nonprofit, health authorities where their purpose is stated. Because the internet's a blessing and a curse, anyone can say anything. But I will recommend that if you find something really great, do not download 100 pages of information and hand it to your doctor. This will not go well, I guarantee it. So make something concise if you feel you need to share that with your doctor. But this is how you can research and develop the appropriate questions for your doctor. Next slide, please. So how much information do people accurately remember at a medical appointment? Well, the stats are they remember 50%, and of that 50%, half of it is wrong. So now we're down to 1 out of 4 things that people actually recall correctly. Now, I don't know about you, that sounds serious to me. We're talking about medications, interventions, procedures, advice, and people aren't remembering. So this is just one of the many reasons you need to be planful about your medical care because you're missing out on a lot of information. Next slide, please. You always want to bring somebody with you to a medical appointment. Now, obviously not, maybe for an ingrown toenail or something, but generally speaking, yes, you do. And the reason you do is you want to have somebody who knows you because they are maybe noticing things about you that you're not. You want to perhaps even record a visit. And I will say respectfully that you can say you would like to, or you're going to do that. You're not really asking permission. There's nothing wrong with recording an appointment. Often it's better you can share it with another family member, and that's wise of you to record it where anything is complex so you can listen to it later. But this, once again, is how you help your doctor help you, is by being on top of things. Next slide, please. I suggest to you that you bring a notebook to all medical transactions. And I know that a lot of people are using their smartphone these days, but often really a simple notebook is a better idea. It allows you to write down your medications, which includes all your over-the-counter medicines. You can put down, what the dates medicines were changed, because we always forget. We're like, oh, that was 2 weeks ago. And then it's like, oh no, actually it was 4 weeks ago. And we forget the dates of tests and procedures. We forget our symptoms, what made us better, what made us worse. We forget the name of specialists that we've been referred to. When did we see them? What are our allergies? When are our other appointments coming up? So this is your special little book that is very helpful. And it's also helpful to have a book because then other people can collaborate with you, other family members. If you don't have that book and you're using your smartphone, then, probably people aren't following the list you're keeping. But once again, you need to be able to keep track of following up on test results. You want to remember what it was you even spoke about at your last visit. So this is really important. And you're also, of course, planning for your appointment with a physician, and you're wanting to write down your questions. So this notebook can be very valuable to you. Next slide, please.
Okay.
I suggest that you ask questions at absolutely every opportunity so that you have informed decisions and informed consent. So these are questions about your diagnosis, your treatment, the medicines, and this is how you improve the quality and the safety and the effectiveness of your healthcare. Now, you probably don't know this, but on average, doctors first interrupt their patients anywhere between 12 to 15 seconds into the interview in a medical appointment. And this is one of the reasons you need to prioritize your questions and be prepared to be cut off and be prepared to say that you weren't finished what you need to share. And you'll have that information handy in your notebook if you're feeling nervous. And you know, what is the rush? Why are they so quick? Because they are pushing through so many people in a day in a complex system. They're running a business, and once again, it's, you know, money, money, money. I do think that the system is making it difficult for people to do their job well, but at the same time, I think healthcare providers and a lot of people could just go the extra mile, and unfortunately, they're not. Where you don't have your questions answered, if you're polite and reasonable, nothing wrong with making a follow-up appointment, and people can be respectful. And I want to point out to you, if you're taking note of a website that is called Canadian Patient Safety Institute.ca. That website gives you the kind of questions you ask before, during, and after an appointment, and it gives you an entire checklist. So looking at the Canadian Patient Safety Institute.ca is wise to help you prepare. Now, it is important to keep copies of everything, and I know everyone is of the mind, oh, well, it's in my record and everyone can see it, but it's amazing how suddenly these things are hard to get a hold of. So when you are at the point of care, when you're being given a test result, that's the time to ask for a copy, and sometimes you aren't charged if you get it right then. If you go back later and ask for a bunch of things, then you know there'll be a bill attached to that. But often you having a copy means that you can show that to another provider who doesn't have the result, maybe a CT scan. You maybe have family members, friends, other people who do understand these documents. So you don't have to feel shy to ask just because you don't understand them. Next slide, please. You do want to create an electronic record if you're tech savvy, because it's handy. Over the years, just accumulating all this information can be helpful. I threw up a couple of ideas there, Dynacare, CARP 360. There's many of them now. There's free ones. There's ones that are part of a membership. There's many options, but you know, practically speaking, if you're having a lot of test results, then it is nice to have a place to put them that you can access later. Next slide, please. It's very important to confirm your diagnosis, and that's because the misdiagnosis rate is 10 to 30%, I'm sorry to say, and it's up as high as 40% in the emergency room. Now, I share that with you not to scare you, but more to say that your diagnosis sets the treatment plan. It sets the trajectory. So if you have the wrong diagnosis, then what's happening after that is probably not in your best interest. So, you know, there's a lot of conditions that mimic other conditions. It's no easy task to make diagnoses in the emergency room. So this isn't a matter of criticism. This is just a matter of giving you the facts. So along that same line, you know, you're entitled to a second opinion. That's part of that card that gets swiped at every visit. So people feel shy to ask for that, but I guarantee you that when your physician has a serious medical problem, they're getting a second opinion, and you don't need to be shy to ask for one. You know, experts would tell you anything serious requires that, and that would mean like surgery, chemo, things like that. But I invite you to know yourself, if you feel like you need one, to trust that feeling inside of you to get a valid second opinion. you know, communication is really key in healthcare, and this is the piece that gets dropped. So, you know, also telling doctors, you know, in terms of a diagnosis, you know, you see them and then you go home and maybe your symptoms get worse or you have side effects from a medication, you know, they're not mind readers, they're not psychic. So often people are at home angry about what went on with the doctor, but if you don't communicate with them and tell them what's happening, they also can't help you. Next slide, please. I just want to go over a few tips for hospital care. So I want you to think about that notebook. Now, most people wouldn't think of taking a notebook if they were hospitalized, but imagine, here you are, if you're in hospital these days, you are sick. They aren't admitting anybody unless you're very sick. And if you're sick, you're probably tired. You might be confused by all that's going on. You may not be sleeping because you have a neighbor who's up all night or who is ill. You're being bombarded with medical terminology, maybe pain medication, and on it goes. That notebook can be very, very handy because you can ask nurses to write down when they give you that pain medicine so you can keep track. When doctors come in that you don't know and you've never seen before, you can get them to write their name down and spell it out. You can get them to write down the name of the test that they're saying you're going to have. So when your family comes in later, that you can tell them what happened, who was there, and what the plan is. You know, it's really, really tricky to navigate the hospital system, and it's not any better these days. But you know, the reality in hospital is 1 error per patient per day. And so now that's everything from giving a medication a little late to operating on the wrong body part. So not to scare people, but you don't want to be in hospital any longer than you have to be. And you've got to be watching out for trouble because there's errors happening all the time. So, and whenever possible, I prefer that, you know, not to leave people alone at the hospital. Next slide, please. In terms of safety, it's very important to use the same pharmacy year after year because they track things, they're looking at interactions and so on. They give you the medication list for the wallet, and you can ask them to do, you know, things for you that are important. Maybe you need large print on bottles. Maybe you need easy open lids. Maybe there's trouble swallowing and you want them to help you get switched over to a liquid or a patch. They should be working for you, and they've taken a lot more responsibility in healthcare than they ever did, and they're there to help you. But you know, where you stick with the same pharmacy, you can talk to them when you're buying over-the-counter medications so that they can tell you if there's any contraindications. So, and if you ever need to change pharmacies, you go to the new pharmacy and you let them take care of it. You never have to be involved in changing pharmacies. And I highly recommend the small, close to home, not the big box pharmacies if you can avoid it. I cannot tell you the number of medication errors coming out of these big pharmacies. It's frightening. Next slide, please.
1 sec.
Mm-hmm.
There we go.
And while we're talking about medications, I just want to say to you, never start 2 medications at the same time because you can't tell if you have a problem, which one's the problem. You also can't tell which one's helping you, and so sometimes you don't need both of them. So you have to be planful about medication, and also you need to know that as we age, we change. So a medication that was good for you a few years ago may not be good for you now. So this is why any new symptoms should be considered a drug side effect until proven otherwise. People are often on a long list of medications, and so they assume they've got some problem, and it may just be a problem that's right in front of them in one of these pills. So don't overlook the pills as a possible source of trouble that people are having, especially people with a lot of chronic health conditions. Right, so it's, you know, ultimately the person taking the medicine has to take responsibility for it, and where you're a parent of somebody who needs your support with that, I ask you to really think very seriously about every medication that's going in that mouth and if it really has to be, because healthcare providers think about the most common side effects, and so when you tell them that you think a medication is a problem, they'll tell you, oh, no, that's not a problem. Well, the reality is if it happened in 1 or 2 or 3 people at 100, they may not have paid attention to that, but you could be that one. And so you need to do your own research. You are a unique individual, and so even those remote possible side effects could be yours. Next slide, please. It's very important to consider polypharmacy, which is, you know, excessive use of medications. And so I'm just pointing you to this website, deprescribing.org. And, you know, because we have a society that's looking for a pill to solve everything, and also a society that has so many chronic health conditions, people are taking medicine more than ever. So this website is filled with information, and you know, I'm not suggesting people go and stop taking medications on their own by any means, but there's a lot of information here. Next slide, please. And this is the same organization, Canadian Deep Prescribing Network, with a lot of great information that you can go to. And it helps for you to understand safety issues and so on around medicine in Canada. Next slide, please. They have a section that's for patients and the public, and also for healthcare professionals. And once again, I can't emphasize enough, I'm not recommending that people stop taking medication, but I want them to be empowered to know there's options and there are ways of getting off of medication. Next slide, please. This is important as well, is to just understand that there's many medications that have very serious consequences if stopped abruptly. So you do need to work with a physician when you can to come off of medication. But you know what? You know, you're not asking permission, you're saying what you want to do. And so you're asking for support to do it right. And this is what I recommend people do. Next slide, please. There is this website also, mentalhealthdaily.com, and that's advice for medication withdrawal on psychotropic medications, medications that affect mood and behavior and emotions. So once again, not supporting to do this without medical supervision, but I happen to know I've come upon people who are so frustrated by the system that doctors wouldn't hear them and they went ahead and did it themselves. So this is a website that is providing some guidance in this regard. Next slide, please. I would be remiss in not commenting on the fact that we are biopsychosocial beings, body, mind, spirit. You can't separate them apart. And the medical model does not acknowledge this very well or often in practical terms. So I bring that up because we do have thoughts and feelings around what we want for our bodies. And what we want needs to be honored, because what I want for me is not what you want for you or your loved ones, and so on. And so once again, in the medical model, they think they know it, they think they've got it, and we should all just get to it. But the reality is that we are in charge of what we want for us to the extent that we can be. And I really honor, and I would like you to, that patients have insight, they have intuition regarding their circumstances, and it really does need to be honored as much as test results are. Next slide, please. You have the right to look at any and all options, and I just popped a few up there just to give you an idea. You know, it has nothing to do with my preference, but people are entitled to use cannabis. We see wonderful results with cannabis use for pain management. Bowen therapy is a fascia work therapy that works wonderfully well for all sorts of pain that isn't solved through the regular ways. Medical assistance in dying is something that is approved in Canada, and people should have the right to. And you know, it's not about promoting these, but supporting people's rights to investigate options and choose what's right for them. And you see a little picture there of acupuncture because it's a perfect example of something that's been around for over 3,000 years. And, you know, we've got, you know, conventional medicine here in Canada for just over 100. We're really very behind with integrative medicine and complementary therapies in Canada. And so we have to make it our own business to look out at what are the options, step out of our comfort zone, keep an open mind, and look around to see what might be other options that the doctor is never going to tell you. Next slide, please. In Ontario, I just want to point you to a website called healthcareathome.ca. And what this points to is that in Ontario, there is 14 LHINs. LHIN stands for Local Health Integration Network, and this is where the publicly funded healthcare, home care comes from. And you can go to that website, you can click on the LHIN that you are in. In Ottawa here, we are number 11 in the Champlain LHIN. And you know, this system actually was to be phased out in April, but with the pandemic that is on hold. But Ontario Health Teams is the new model that is to be taking over in Ontario, but we'll just see how that unfolds. I don't expect things are going to get better anytime soon. Right now, we're in quite a mess in Ontario with over 30,000 people on the wait list for long-term care. So we are really challenged here, and the people that are living in these long-term care facilities is a whole mixed bag because there's just nowhere for people to go. People with disabilities, people with any mental health issues, you name it, they're all together with the elderly, and it's a dog's breakfast would be an understatement. Next slide, please. So what does the LIN do? Well, they handle all the community care and run the funding for that. And most would say they're not doing such a hot job. Now, that's my experience anyhow. Next slide, please. Home and community care obviously involves nursing, PSW, occupational therapy, and so on at a very minimal level. So part of our role as patient advocates is to make sure people are getting what they deserve. There's a lot of people eligible, but they get denied. And so there's a lot of advocacy around getting people what they need to stay in their own home, and which is the best place for people where they can be. Next slide, please. And you may be familiar with community social support services, and these are subsidized services, very limited. There's not a lot of that available. Sadly, people think there's going to be a lot more available to them when they're ill, but that's just not the truth. Next slide, please. So the private sector has to cover many of the things, such as we do, care management, but all these other things that people have been paying for a long time out of pocket is why they have to reach out to the private sector, because they can't get this support any other way. Next slide, please. And of course, who does what? Well, the family and friends are doing everything under the sun, and they are tired, overwhelmed, frustrated, exhausted, like anybody, good days and not so good. But it is extremely challenging, and caregiver burnout is huge. The impact for families is substantial to have somebody who has any health matters, because the system is sadly lacking in support. So it's sometimes the reason we're hired is just to make sense of it all and support families so they can get through these things. Next slide, please. And that is why we're here to help people. We really do intervene at any time that they need us to. And so in any way that they need us to, because we're very holistic in our thinking. And so we do deal in situation where there's, guardianship matters sometimes, power of attorney, abusive power of attorney, very complex medical situations, mental health matters, you name it. These nurses are very highly qualified. And where we can, we want to empower our patients, their families, to do anything they can do. And where we can show them how to do it, then they just have us as a backup plan. Next slide, please. I believe that the solution lies with those who are situated close to the most vulnerable in our community. And so I would call that seniors, young people, those with disabilities. And I really see this as a social issue where we're, people as a society are very attached to the TV and the people on it, but don't know much about their neighbors and aren't caring for their own loved ones, which is a real sad reality. So, I think that we can all do better. We can be empowered around healthcare. We can support our family and friends, that they don't go alone to these medical interventions and appointments and interactions and then come away feeling, really disturbed, upset, sad, frustrated. All these things can be helped by having support. And so just for your understanding, yes, we are a privately paid service, but we are an eligible medical expense for income tax. We are HST exempt, and we are a great backup plan for people who need it. And sometimes people in the situation of this audience, sometimes they just need somebody to to lean on, or know if they know they're going to be away for a vacation, somebody they know that could jump in and handle things that are complex. So we're happy to hear from you. We give a free 30-minute phone consultation if we can support you in any way. And, just to answer your questions. So feel free to reach out by email or phone. I'm happy to take your questions. We have a large team here in Ottawa, and we actually have a nurse who specializes in people with developmental disabilities. Boy, oh boy, the stories are rough, Ken, for people in that circumstances. The inequities in healthcare for people with disabilities is frightening. It's some days it's an embarrassment to be a healthcare provider, because people might whitewash all of us the same way, Anyway, thank you very much.
I would think that in today's world, like, for example, I have a simple medical appointment coming up, and it's going to be a Zoom meeting. I don't see why you couldn't provide services across the province. I mean, why couldn't you join into a Zoom appointment with a doctor in Sudbury?
We do, actually. Yeah, we are in 8 regions of Ontario, but we can see people anywhere in the current environment. It's true.
That's what I thought, yeah. Well, I'd like to just make a final sort of anecdote, and then Dianne, if you would say a few closing words, and thank everyone. The families that Dianne and I work with, the firm itself, they all have skin in the game, you know, and they're all committed. They're lifelong advocates. You know, they're brave families. You know, being brave doesn't mean you're not afraid. It just means that you act in the face of fear. And my client families just get up in the morning and put one foot in front of the other. And the way I like to look at it is that if you look at all of the well-meaning, well-intended, supporting professionals and the family and the child, if you look at them in the context of an egg and bacon breakfast, the chicken's involved, but the pig's committed. So, you know, that's the proper humble context that you have to take from this. We're just people that are trying to help the people that are doing the real job. Dianne, would you say a few closing words, and then we'll all be done. It's 20 after 8. I think we've done a really good job.
Yeah, I think this was a fantastic webinar. I certainly learned a lot. Thank you, everybody. You know, what I want to say is we're here to assist. Everyone on this panel is here to assist you. And if we can strengthen you and your advocacy for your family member with disabilities, we're happy to help.
Now, we'll be sending this recorded YouTube video, Zoom video, and the PowerPoint slides to everyone who's registered. And I see that we had at the top, what did we have? What, 105, 110 attend. And we had, I think, 327 register. So it's, you know, that's just how it is. You know, even when these things are delivered to somebody's home, things come up. When we do our surveys and ask people why they, for example, you know, we can see that their child's at home, they're getting $8.96 a month. We could probably get them $11.69. We contact them and say, you know, would you like to be assisted? The response rate is low, enough to keep us busy, which is good, but low. And when we do our surveys consistently, the factor is, well, the reason I haven't done my will is I'm busy with my child. I had appointments to go to. There was a crisis, you know, and that's the same thing with everything that our families do. So that being said, we understand. If anyone does have any further questions, I think we've done a pretty good job answering, but if you have any further questions, send them to karen@kpopelaw.ca or specifically directly to Susan or Lisa or Dianne if it's Guardianship, and we'll be happy to help. So that said, thank you for everyone for taking part. And I'll close this off, and we'll tidy up the video in the next couple of days, and everybody will receive it.